Hi, this is Clyde Yancy from AHA Scientific Sessions 2022. We've just completed discussion of the first session of the late-breaking clinical trials, where we heard really striking evidence sufficient to help us understand how we might indeed change practice. I'm delighted that Dr. Ishani is with me. He was a principal investigator for one of the most important trials called the DCP Trial. Now, what is that? It was a trial conducted in the VA population intended to demonstrate whether or not there is a difference between using hydrochlorothiazide as treatment for hypertension versus chlorthalidone. Many of us go into this discussion thinking that chlorthalidone clearly would have been the preferred agent, particularly for secondary disease, and maybe it still is a preferred agent for advanced stages of hypertension. But for the ambulatory patient, as seen in this VA population, this was the question on the table. Boy, did the audience do a double take when you showed the outcomes. No one expected it to be dissimilar, but incredibly informative. Tell us a little bit about the trial.
Yeah, so I'm with you. We were all going into the study thinking that there's no way chlorthalidone wasn't going to win, but there was no difference, again, as you said, in the primary outcome, which is a major adverse cardiovascular event or non-cancer death or any component of the primary outcome. So it was a surprise. You know, the one thing that's probably a caveat is that the prior studies that had suggested benefit all used higher doses. And so typically it's 25 or 50 milligrams of 25 milligrams of chlorthalidone, 50 milligrams of hydrochlorothiazide. You know, 95% of our population was on a low dose, so 25 of hydrochlorothiazide, which then got switched to 12.5 of chlorthalidone. And I think that might be some of it.
But isn't it fascinating that we're still having conversations about the best way to treat hypertension? I mean, that was the source of our original randomized controlled trials, back not to the 90s or the 80s, but back into the 70s. This is when we first started thinking about, well, can we study this? Can we define the threshold blood pressure at risk and figure out what might work? I was really pleased that Dan Levy contributed a really crisp summary of what the predicate knowledge taught us about chlorthalidone. We should not dismiss that, because we see, particularly compared to placebo, really important benefits on outcomes that matter. But as we go forward in practice, and as you point out, particularly at these lower doses, which has become the norm, whether it's normal to use those lower doses, it's become normative behavior, we don't see those differences. But let's push the edges a little bit and go in two directions. One, let's talk about the effect of these thiazide agents on electrolyte perturbations. That could potentially be quite important. And then let's think about applying it to the contemporary clinical context for that patient that is referred to a physician because the blood pressure is difficult to control. So let's talk about the electrolytes first.
So we did see a slight increase in hypokalemia in the chlorthalidone group compared to the hydrochlorothiazide group. Again, this might have been a study design related issue. So we took individuals who were on a stable dose, on stable potassium supplements, and we either left them on their stable dose of hydrochlorothiazide, or we switched them to something that was new to them and to their provider. We didn't mandate any labs or anything.
And new to their kidneys.
And new to their kidneys, absolutely. So what we did see is that individuals who switched to the chlorthalidone had more frequent lab monitoring. And I think that's the reason. So it's new to them, new to their kidney, and new to their provider. We found more hypokalemia, which caused us to treat it. We might have put them in the hospital. I think there was a few more hospitalizations. That was not significant. So I think the hypokalemia is likely study design related.
But I'm pleased that we didn't see frank azotemia or any sufficient changes in renal function that would have raised a concern of renal injury. And we always worry about that in older patients where we're dosing diuretic therapy. So let's go to the second part of this and then we'll wrap up. For that patient that many doctors see every day, my blood pressure isn't controlled, can you help me? What would you tell that physician about the choice of thiazide diuretic in that setting, assuming renal function is appropriate for thiazide?
Yeah, so our study says that the two drugs are equivalent, again, at the doses we looked at. I think it's easy, so it seemed to me easy, so our average blood pressure is 139, and everyone's on a low dose thiazide. It would have been easy for everybody to step up the drug. So it's, might be harder to go from 25 to 50 of hydrochlorothiazide, but we were asking patients to split pills to get to 12.5 milligrams. it seems to me, I thought all the providers would say, well, instead of taking half, take the whole thing, because your blood pressure is already 139, you can tolerate a slightly higher dose. And so I think that's an easy one. So if you wanted to do either step up, which is a little harder, or convert 25 to 25, everybody thinks they're getting the same thing, but it is definitely more potent.
Yeah, no, I follow that dictum in my own practice. I'll take someone on 25 of HCTZ and go 1-for-1 to chlorthalidone, right, knowing that there's actually a bit more effectiveness that's likely to be had with that strategy. Well, I want to congratulate you for doing a trial in the theme of the way this was organized, that is changing clinical practice. I think your data changed clinical practice. If you're treating hypertension, really remove these hierarchical schemes from your mindset. Get the numbers where they belong, the point that we tried to emphasize during the session. That's the real key. And whatever is available, use that agent as appropriate.
Absolutely.
I want to thank you for this.
Thank you
really
very
great
much.
work.